Hey everyone, let's get right into breathing then. Now we've talked about all the organs, we've talked about some disorders associated with those organs. Now let's talk about what breathing is. So breathing, known as pulmonary ventilation, is a cycle which includes an inspiration and an expiration. So that's one cycle, okay? And there are four simultaneous processes occurring during this cycle. So you have the pulmonary ventilation, you have alveolar gas exchange, so exchange of nutrients with the blood and waste products back to the lungs. We have gas transport, so movement of nutrients to our tissues, and then systemic gas exchange, where those nutrients leave the blood and waste products get picked up by the blood. So let's look at each of those steps individually. So pulmonary ventilation, which is your breathing, is the movement of air between the atmosphere and the alveoli. And that is two cycles, an inspiration and expiration. You can have both quiet breathing, so when you're breathing and you're not doing anything, so maybe reading a book, studying, watching a movie, sleeping. And then you have forced breathing, breathing occurring associated with doing activity. So if you're exercising, if you're talking, things like that, you're forcing your breathing at that time. Pulmonary ventilation occurs because we have muscles, we have skeletal muscles that contract and relax, allowing us to breathe. So it is an autonomic process, which means we don't think about it. We don't have to think about taking a breath every time we take a breath. But it is skeletal muscle, which means we can control our breathing. So how many people have ever held their breath? And I know if I asked you to raise your hands, you guys would all be like, oh my God, you're so silly. But you all would either raise your hand or would know, yeah, of course I've held my breath. Everybody holds their breath at some point in their life when you jumped into water or something. And that was you controlling your breathing with your skeletal muscles, okay? But we don't think about breathing, which makes it an autonomic process or automatic, okay? Muscles contract, which increases the size of our thoracic cavity, which decreases the amount of pressure in our thoracic cavity, and that allows air to move in. When our lungs relax, that our muscles go back to their resting structure, which increase or decreases the size of the thoracic cavity, increasing the pressure in the thoracic cavity, and air moves out. So inhalation is an active process. You need energy, ATP, to inhale. Exhalation is typically a passive process unless you are coughing or forcefully exhaling. So we have muscles of breathing. Some of these muscles are associated with quiet breathing, and some are associated with active breathing. So the two muscles that we talk about most for quiet breathing, that work both in quiet and active breathing, are your diaphragm and external intercostals. So the diaphragm increases the size of the thoracic cavity. When it contracts, it moves down, pushing on the stomach. So pushing down into that abdominal pelvic cavity. That increases the size of the thoracic cavity. When the external intercostals are stimulated, they move outwards. So they pull the thoracic cavity anteriorly and laterally, and this increases the size of the thoracic cavity. And then when they are no longer stimulated, they go back to normal size, which decreases the size of that thoracic cavity. So let's look at Boyles Law then. So do you remember learning about these different gas laws in your chemistry class? If you haven't taken a chemistry class, and you'll learn about all of these gas laws, but if you have and you remember them, now you're going to apply them to the human body. So Boyles Law states that at a constant temperature, the pressure of a gas decreases if the volume of a container increases. And so there's an inverse relationship between the volume and the pressure. If you have a large volume, you have a low pressure. If you have a small volume, you have a high pressure, which makes sense. So as we get ready to inhale, the thoracic cavity gets large, and so it's under lower pressure, and air moves from higher to lower pressure. So the atmospheric pressure is going to be higher than the pressure in our lungs. Air moves in. But when our thoracic cavity goes back to its resting shape, we now have a higher pressure in our lungs than in the atmosphere, and air moves out. So inspiration and expiration occur because we have the expansion and contraction of our thoracic cavity. So what is atmospheric pressure? Atmospheric pressure is associated with the air in the environment. And it's the pressure the gases in the air exert on the environment. So at sea level, our atmospheric pressure is about 760 millimeters of mercury. And that's the same as what our lungs are at. Our lungs are at about 760 millimeters of mercury. Interpleural pressure is always going to be slightly lower than the alveolar pressure. And that has to be that way. If interpleural pressure increased, then that would cause our lungs to collapse. If we increase in altitude, then we lower the pressure of the atmosphere, and that changes the ability to breathe. So most people think of, oh, the air is thinner up here. And if we increase or if we decrease our altitude, so we go below at sea level, then we increase the pressure, and so air becomes heavier in that area. And so more air is going to push in. And both of those can cause different problems, which we'll talk about. So I mentioned interpleural pressure is always going to stay lower than our pressure in our lungs, because if it increases higher than our lung pressure, then our lungs would actually collapse, and that would cause all kinds of problems. So let's look at some of these pressures associated with breathing then. So tidal volume is the amount of air that we take in per breath. So typical tidal volume is about 500 milliliters of air comes in, and that actually allows us to determine the amount of air moved per minute from the alveoli. If we count the number of breaths, which is our respiratory rate or respiration rate, we can then multiply the amount of air that moved in times the amount of breaths, and we get a rate of, depending, but an average rate would be about 6 liters of air being moved every single minute, and that's normal. Hello. Hold on. There we go. Okay. In our lungs, there's a region called dead space. So this is where no exchange of gases occurs, but there's always air in that region. And so that's about 150 milliliters of air that's always in an area called the dead space. And then we have the region, so if we look at the amount of air that's actually moving into our blood, we can take the tidal volume minus the anatomic dead space, and then multiply that by our respiratory rate. That gives us what we call alveolar ventilation. And so the amount of air that actually is moving into our blood is about 4.2 liters per minute. So not the full 6 liters, because there's always that air that's in that dead space. We can actually use a tool called a spirometer to measure the amount of air that moves into and out of our lungs. So if you've ever been in a hospital or in a doctor's office due to a respiratory infection, oftentimes they will have you breathe into one of these tools to see if you're getting enough air or if you can blow out enough air. And so they do this and they test you, and then they can diagnose different disorders associated with your breathing. So here we have a graph that shows multiple types of breathing. So we have what we call our tidal volume. So that's that 500 milliliters of air that is typical, 500 milliliters of air, 500 milliliters of air. That's what we normally have. Then we have this inspiratory reserve volume. So the inspiratory reserve volume is the amount of air above and beyond that tidal volume that we can take in. So when you're getting ready to jump off of a diving board, you go and then you jump. That was the inspiratory reserve volume that you were filling your lungs with so that you had enough air to make it until you came out and could breathe again. We also have an expiratory reserve volume. Expiratory reserve volume is the amount of air that you can exhale above and beyond the tidal volume. So think about blowing up a balloon. That extra air that you're pushing out is your expiratory reserve volume. So if we add the tidal volume to the inspiratory reserve volume, we get our inspiratory capacity. If we take the tidal volume plus the expiratory reserve volume and we add in the residual air that's always in our lungs, we end up with a functional residual capacity. So the vital capacity is the tidal volume, the inspiratory reserve volume, and the expiratory reserve volume. So that includes our the vital capacity. That's all the air that we actually are moving, are able to move. Total lung capacity includes everything. That would include that residual as well. And so here you can see, like if you're trying to figure out how much your forced vital capacity is, you can look at how much air can be exhaled after a maximum inhalation. So you can read these, and these are some of the things that they're going to test in a pulmonary function test, okay? And that this table is also in your book, so if you can't read it perfectly here, you can find it in your textbook, okay? So we don't have, our lungs or our diaphragm doesn't have any pacemaker cells, so it doesn't cause, we don't breathe without nervous innervation. We actually have a nerve that stimulates breathing. The phrenic nerve moves from the brain, from the spinal cord, and it moves to, so it takes information from the brain through the spinal cord, and it moves to the diaphragm. And it's what stimulates breathing. So we have a region in our brain, in the medulla, as well as in our pons, but the medulla is the major area for breathing, that stimulates the control of breathing. And then the pons stimulates the medulla. So it's kind of like they work together to help us to breathe. And this is your unconscious breathing, so that autonomic breathing that we talk about. But there is also conscious breathing. So Conscious breathing, your cerebral cortex, we can control our breathing. Like I said, you can hold your breath, you can blow a lot of air out. So you can consciously control your breathing. You can try and slow your breathing even when you're breathing very fast. The hypothalamus is going to, if your body starts to warm up, is going to cause you to breathe faster. And your limbic system can alter your breathing associated with emotions. So you might breathe heavier if you're in certain situations. You might breathe lighter in other situations, depending on if you're scared, frightened, excited, depending. Okay? But these are all conscious breathing. We have receptors associated in, or we have multiple receptors found throughout our body that are associated with breathing, and they help us to breathe associated with what's going on in our body. So we have chemoreceptors in our blood that are going to detect changes in the amount of carbon dioxide, in the pH change, as well as minimally oxygen changes. We have proprioceptors that are found within our joints that determine changes of our body position. We have stretch receptors in our blood again that are going to determine how much fluid is moving, and that will determine if we need more or less oxygen in our system. And then we have irritant receptors that stimulate us to cough and sneeze. I'm going to stop here because it's been a 16-minute video, so I will pick up here in our next video. Bye.